Temporary.
Welcome to the first educational, I think it's community educational forum that the Ending Homelessness Fund is putting on. And we hope this is far from our last one. As a matter of fact, the next one is all scheduled, so put it in your little brains, September 23rd, same time, same place, same amount of food. Oh, I'm getting the signal. No, this is this one is going to be the September. Is that right? Take it out of your brain, we'll let you know. September 21st. Wow, I better get my brain going. I'd like to say a couple of words. The Indian Homelessness Fund is a fund that takes care of our most vulnerable, which are the chronically homeless, and that is really not the topic tonight. The topic tonight is behavioral health issues and homelessness. Let me give you a little bit of background for those who don't. Well, let me ask, has anybody not been to Harbor Homes before? So you all really been here. Well, let me say a couple of words. What's that? Yes, I saw two hands. You see this partnership for successful living. Then you hear about Harbor Homes, and then it gets a little confusing, to me anyway. If you look at the bottom of the Partnership for Successful Living folder, you see 6 different organizations which are all under one administration. The CEO is right here for all of those. Harbor Homes is part of that. Say, why do you do that? Well, to end homelessness one person at a time requires a lot of different services, not just one. And that's why there are a lot of different specialties to meet the needs of our people. So what are we going to do tonight? Tonight, we're going to talk about behavioral health and homelessness. We're going to start with Peter Kelleher, our CEO, and he's going to talk about, okay, you ready? Housing first. And I'd like you to put that into your noggins, housing first. The reason? That is probably the technique for ending homelessness in our community and perhaps in our country. And Peter's going to tell us what that's all about. Then, after he finishes, and I've got the microphone in case he talks too long, we have our panel. Our panel consists of 3 behavioral health staff members and 2 of their clients. The clients are here to tell us their story, to make this real. This is no longer statistics. This is real. And then when you leave, over at that desk, I'm going to show you something. 1 second. Would you hold that?
Sure.
I pull out my wallet, and here is a car. When we bump into people who need the services from here, we have this wallet card, and we're ready to give them the number, 2 numbers, and I'll tell you that later. And we're a team.
Yes, we are.
We have some extras in our wallet. So I would encourage you each to get a wallet card, so when you are in that awkward situation where you know that $2 is really not an answer, that you have something better than that to give. In addition, after the program's over, and hopefully the food is all eaten, those of you who would like can have a tour of the brand new medical center in this building, and Tara is going to be at the coffee urn, and if you'd like to take a quick tour around and see what's going on inside these walls, there's your chance. Let's start with Peter Kelleher. Now, Peter's been here a while. He was the first hire, I believe, in the 1980s. And he will not like what I'm going to say, but I'm going to tell you anyway. He knows more about how to house the homeless than he knows as much as anybody in this country. For instance, the White House has a small group that meets to talk about the issues with the homeless veterans. Peter is there. He's part of a small group. We're very, very lucky to have him and his imaginative mind in our community. So he's going to start. Peter, I give it to you.
Thank you, David. Can you hear me okay? Yes.
Well, that was a wonderful introduction. Um, I'm left-handed, so I'm on this side. On behalf of the Harbor Homes and the Partnership for Successful Living Agencies, please let me express my a warm welcome to all of you for coming here and having this conversation with us. That means up here, I suppose? Yeah. Thank you. You know, this is a very informal evening of conversation and communication for us to talk about homelessness and all of the issues that they face. And I'll just start off by saying we're all familiar with the gamut of emotions that we experience when we walk past or hear our homeless neighbors, or hear about our homeless neighbors that may be living, say, under a tattered blanket or a cardboard tent, sleeping on a park bench, or the classic things, take under a bridge or in a car. We empathize with their pain and their suffering, but at the same time, we feel a little powerless to change their situation. Understanding homelessness is a fundamental step toward ending it, especially for those persons living with a chronic condition or mental illness, an addiction, or a physical disability. Homelessness doesn't discriminate. It can happen to anyone. Mental health issues complicate and play a significant role in the ongoing crisis of homelessness. It often results in an inability to acquire the skills, supports, or solid family and social relationships. It can hinder economic advancement. It can provide a barrier to getting housing. Sometimes just one, or possibly all of these, can shut a person's ability to cope or even hope. Mental illness can greatly increase the risk of homelessness, and at the same time, homelessness can increase the risk of mental illness. By this I mean, after being homeless, even just for a short period of time, one can lose faith in him or herself, can spiral into a feeling as though they have no place in society, which can cause a further spiral into despair and severe depression. So if you stop and think for a second about the life and the day of a homeless person, you wake up in the morning in an emergency shelter, you are surrounded by other people that you may not know all that well, and you have a constant worry about your belongings. Are they safe? Will they remain with you? Who are these other people around you? What are you going to do during that day? Where are you going to go? You're told that you need to get out for the day, and you are told that you need to apply for at least 2 jobs, and that you better be back by 4:30 or you may not have a bed tonight. And there's such a degree of uncertainty in where you're going to eat during the day, and not even think about all of the things that are really bothering you in your life, your family, maybe children or relatives, and what's happening with where you're trying to bring your life into the future. There's a lot of weight you carry. And it's very easy to become despairing, and it's very difficult to ask for help. So, you know, I just wanted to kind of ground you a little bit on what the emotional terrain that people who are homeless often feel as they just try to do the basic navigation of life. So one of the major obstacles that homeless persons face is in seeking mental health is the fear of stigma, at the risk of being discriminated or judged, feeling embarrassed about getting access to medical treatment. People with mental illness can easily slip into a state of complacency, disillusionment, and a feeling of suspiciousness towards treatment. sometimes refusing it altogether, creating barriers, which in turn creates barriers to housing and resistance to others' efforts to reach out to you. Without a stable place to live and safety net of supportive services to help our most vulnerable cope with their underlying problems, most homeless persons rebound from one emergency shelter system to the next, from the streets to the emergency shelters, to public hospitals, to psychiatric institutions, prisons, detox centers, and then back on the streets once again. This seemingly endless cycle into homelessness is very expensive for the community. The exorbitant cost to maintain shelters, the financial strain on emergency rooms and first responders, and extended hospital stays, and result in costs approximating $25,000 to as much as $150,000 or more per homeless individual. In fact, there was one individual in Colorado called $1 Million Murray, as it proved that across the various systems, that's actually the amount that he cost the public sector. So what's the answer? I've been doing this for, believe it or not, almost 35 years this summer. And earlier in my career, I made a lot of mistakes, and I learned a lot of things. And I learned that if you have a homeless person, usually they come and they have several things at the same time, 5 or 6 different needs they approach you for at the same time. And I learned that if you just say, here's a referral to agency ABCD, good luck. Most often, they aren't able to access what it is that they really need to. So Harbor Homes believes in what's called a housing first approach. It's a model which is based on the theory that housing is a basic right that emphasizes the choice of people we serve, emphasizes recovery, and harm reduction. Before people can recover from substance abuse, misuse, obtain employment, cope with mental illness, and be a capable parent, they need an affordable, safe place and supportive home first. Think about it, it's bedrock to all of us. We're going to go home tonight. We're going to have a roof over our head that we know we can rely on. And housing first says you don't have to be sober for 30 days. You don't have to save so much money in the bank. It says, we're going to give you the keys, and this is your home. And then we'll worry about how do we figure out to address the other challenges that you're facing in your life. So, housing really should be looked at through the lens of healthcare. If physicians could ever prescribe on a prescription pad housing as the first form of treatment, that's really how the concept came into being. So the housing first strategy is a sound and smart investment as a way of looking to solving the problem of homelessness, both morally and financially. So with that, I will sit down before David takes the mic. Thank you.
Thank you, Peter. Now we have 3 staff members from the Behavioral Health Unit at Harbor Homes. And Elizabeth McGuire is going to start first. And I'm going to tell you who Elizabeth is. Licensed independent clinical social worker who works here as a psychotherapist. Elizabeth?
Hi, it's nice to see you all here. So as we said, I am a clinical social worker here. I do provide therapy. Can people hear me okay?
Yes, they can.
Hello? Okay. Louder? Okay. So I wanted to let you know a little bit about my work with clients here. I work with people who experience both an increase in the severity of their mental health issues because of homelessness, and also people who are at risk of homelessness because of their mental health issues. So we have a great panel here today. You're going to get to hear firsthand about some people's experiences with this, but I thought I'd tell you about a client who felt a little bit too shy to come today but was okay with me sharing her story. So this particular woman that I work with went to a great college. She got a really nice job after graduation. and unfortunately was assaulted at work. So she developed post-traumatic stress disorder and unfortunately didn't connect with mental health services at the time that that happened, and she turned to alcohol and drugs to cope with it. So she went through a lot of years dealing with her symptoms this way. She ended up needing to move home with her family. So she's still at risk for homelessness because her family does not have a lot of financial resources and they may actually lose their house themselves. So she got into treatment though here. She got into Keystone Hall and she began seeing me for therapy, and she also is seen here for medication management. We began addressing the mental health issues concurrently with the substance abuse issues, and now she's doing a lot better. But I think that that case just illustrates how, a lot of us think that maybe we wouldn't be at risk for homelessness when actually we could be if we became ill or the right circumstances happened that made that a risk factor for us.
By the way, I didn't mention this, but if you want to ask questions, let's keep this a small group that can ask questions. So if you want to ask questions as we go along, just raise your hand and we'll do that and get your question answered. And Elizabeth, I'm going to tell you what I just heard. It is amazing how anyone can slip into homelessness. People that we would never think, including ourselves. Our next speaker, let me get this right, Dr. Susan Fender. Is that pretty good?
Vonderheide.
Close.
I apologize. I'm not doing too well here. Strike two. Dr. Susan. Dr. Susan is a licensed psychologist and a psychiatric nurse practitioner. And she's here with her client, one of her clients, David, who's also going to speak. But Susan, you go first.
Okay. Well, first I'd like to tell you about the clinic that we work in, myself and Elizabeth and then Tara. It's based on the medical home model, and you may not know exactly what that means, but it's basically inclusive. So it has the medical, the behavioral health, and the dental all in one place. And we also happen to have substance abuse treatment, and it's all takes place in this building. The outpatient substance abuse treatment also takes place in this building. So when a person calls in many cases we try to get them to go to all of the treatment, maybe not the substance abuse if they don't have that issue, but I certainly encourage dental care. If they come to me first, I'm asking them to, allow me to take their weight, their blood pressure, and so on. And then, in turn, many times they have other problems like type 2 diabetes, or they have smoking cessation is a huge push. So I do a lot of that kind of behavioral health treatment along with giving them medications. So their symptoms can be depression and anxiety. Sometimes they do have auditory and visual hallucinations, but many times it's more common symptoms of depression and anxiety. And in many cases it is because they are homeless, but they also can have layered into that like the substance abuse issues. So I'll just give you an example of a patient that I just saw a few weeks ago. So the first day she came in, and I happened to have my intern with me because I'm also doing supervision of a psychiatric nurse practitioner intern. So she came in, she's crying, she smelled of alcohol, but not as though she was drunk, but like probably from the night before or in the middle of the night. And she says, I've just been kicked out of my friend's apartment, and it was because she had been drinking and she had promised not to drink. She had just gotten out of a psychiatric hospital, right? So, the psychiatric hospital, that's only going to be for a week or two. Then, out she comes because she had been suicidal prior to going into the hospital. So I'm like, oh boy, this is going to be a tough one. So I gave her, prescriptions. And then she says to me, well, I have no health insurance. I'm thinking, how is that possible? She just got out of the hospital. Well, that it wasn't in place yet because, they do like a 30 days back and that would be paid for eventually, but there is no card. There's no way to go to the pharmacy and get, the prescriptions filled with money, whatever, no money. So down the hall from me is a woman named Molly Little, who we just recently hired. So she is providing some case management. So I brought her, after an hour of getting this woman's background and so on, brought her down to Molly. Molly was able to get her a bed in a shelter for that evening and also to get her prescriptions paid for. And I had kind of deliberately prescribed things that I knew were not going to be a huge copay. And that's one of the things we sometimes face here is it the best medication or is it the cheapest medication? So once they get insurance in place, we do prior authorizations and so on. And we're pretty soon going to have a 340B pharmacy, so then that will also be helpful as well. So she came back in to see me about a week later, and this time she wasn't crying. She didn't smell of alcohol. She had her lists of things to do, including going and applying for food stamps. And then she, was on the medications, doing better. She reported that she hadn't, had anything, no alcohol to drink at all. She then came back in the following week and was a little better yet. And then the other day came in and said that she has a boyfriend who happens to be disabled and does not have any alcohol anymore, like he's in recovery. And the two of them had found a room to rent, which I assume is in a boarding house because she said room as opposed to apartment. So that's still considered kind of transitional housing, but it's better than the shelter. So at least she has a room, and she looked, better again. But, this is a process, and it takes months. So she had entered the intensive outpatient program for substance abuse. So it's not like I could say, oh, pretty soon she'll have a job. This is going to be something where if she has a job in, say, 6 months, I would be overjoyed, but she's not on any disability. I hope she doesn't need to go on Social Security disability. And her age is approximately 33 years old. So, and beautiful woman, and I thought, geez, if it weren't for the fact that I knew all these things about her from the previous times, you would never know that there was anything about her that was any different from yourselves. So anyway, I'll just tell you briefly, I see patients about every half hour, 4 or 5 new intakes every week. I have about 300 patients currently. And, again, I've told you what we offer in terms of the medication management and so on and substance abuse services. I'm supervising the APRN student. I have 2 psychology students that are going to be starting shortly. I'm also on the board of psychology, and they actually allow me to go to my board meetings once a month, and that's great. And I'm on a treatment committee up in Concord that has to do with substance abuse treatment. So anyway, this is my one of my, I don't want to say patient, but one of our clients, and this is David, and he's doing very well, is very stable. So I thought he'd be a good choice to speak next, and he agreed to, which I was overjoyed.
Hi, my name is David Allen. You ask, what do I have to do with homelessness and this program? It's because I was homeless at a time. Take it back a couple years ago, and I was suffering from major depression, didn't really know what to do, so I turned to drugs and alcohol. And I call it a dual diagnosis because it does work off of each other. Ended up getting kicked out of my mother's house for using, then kicked out of my father's house for using, and then kicked out of the next apartment I was in. Then I was homeless on the streets. I lost my car. I was using inhalants, and I was pretty much on the streets in Nashua at the Ash Street shelter, using inhalants and any drug that I could just to get out of the way that I was feeling. And ended up getting arrested because I was found passed out 7 times in 2 weeks by the Hudson police. And they finally sent me to Valley Street Jail. So I was there for 30 days, and they really didn't know what to do with me. And so I got out, and I started living with my dad, and the depression got really bad again, and I turned to drugs again. But because of this program, I came here. I was able to get Medicaid fairly quickly. and I got Medicaid within 2 weeks. Then I was able to, start to talk to a psychiatrist and a therapist and get on the right medications. And that was awesome. And just last week, I celebrated my 1 year of sobriety. And it feels great. I haven't felt as good as I have in like probably 10 years as I feel now. And because I came here and I could talk to the right people, and there's the right programs that we have here. I mean, there's computers for people, and there's resources that they can come here and use. I just feel like more people, I wish they knew about it, you know? And even now, my stepfather has a brother who hears voices and is schizophrenic and ended up stabbing himself 3 times in the stomach a couple weeks ago. And I know what he's going through. I mean, he's not a bad person. He's just a sick person that has a mental disease. And it's not fair to like label people. They need help, and they need to call out for help. Because I was afraid to. I felt very isolated in myself. I didn't want to talk to anybody about it. Because when you're in a negative mental state, that's the last thing you want to do is talk to someone. You isolate and isolate and isolate. And but because I came here, I'm back on my feet, and I'm close to my family. I went to Elm Street Middle School, and I spoke at a Red Ribbon Week for them, an assembly for all the kids about drug addiction. Yesterday, I was doing a couple health classes with drug addiction, helping kids. I was on WMUR for a heroin addiction piece that we did. The Farnham Center, I'm very close with them, and I know all the counselors there, and now I know how to help those people and kind of give back, and that's how I root my sobriety and my stability, is giving back to other people and showing them that they can get better. Like I said, they're not bad people, they're just sick people who need help. Like if you lose a leg, you go to physical therapy and learn how to walk with prosthetic. It's the same thing with a mental addiction. You get your help so you can get your life back together. Thank you. Yes, sir? Sir? Oh, okay.
Maybe I should ask Peter to answer that question. Because I'm not sure I can answer.
We do partner with both hospitals here, and actually very soon we are anticipating opening up a new program called Medical and Behavioral Health Respite that will work with people who are, say, using the emergency rooms as primary care, or a place for homeless persons to prepare for procedures that they may have in the hospital, or a place for, say, were homeless and you had cardiac surgery, a place to come out and rehab instead of being in a shelter. So yes.
It works both ways.
Absolutely.
They don't want homeless at the hospital, and you don't want people who need medical care here. You want them at the hospital.
Well, it depends on the level of acuity, I guess, but we do have medical staff here. We have a full federally qualified health center downstairs in this building, and one of the things that was said probably before you got here is that we're happy to give people a full tour so they can see the scope of integrated care that exists here in this building, that's dental and primary care and behavioral health and substance abuse.
Any more questions before we? Yes.
I actually wanted to ask David, how did you find out about Harbor Homes?
The question, just for the audio, is how did you find out about Harbor Homes?
Right. Well, my mother was worried sick, pretty much. She was the only person I talked to about my depression and anxiety and drug abuse and stuff like that. So she was kind of the voice of reason, I would say. And because of her research, she found this place. And thank God, because people can go and this place will pop up and it's a resource for them. I wish there was more that could help people who are homeless, also that have drug addiction, because even, like I said, my stepfather's brother, he has nowhere to go right now. He's in a hospital and he's getting discharged and going back to the house that he was at by himself. I mean, there's nowhere for him to go. So that's kind of a crisis we're even trying to handle right now. So just my mom going hard, kind of trying to find a place for me. Yeah. You're welcome.
Yes.
Can anybody walk into that door and ask for help? And does it take a lot of red tape? Because the person I'm thinking of it does not want to fill out paper or anything like that.
I'm actually going to talk about that.
Good.
Any more questions? Yes.
So one of the issues with individuals who might, one of the issues with people who might be in recovery who are homeless is they are oftentimes afraid of shelters because they're afraid of being triggered. They're afraid that they'll be associating with people who are also having addiction problems not under control and then lure them back into a situation. So what kind of resources are available when you have an individual who is homeless at the time and is in recovery and has nowhere to go? What are the resources that may be available to them where they're afraid to go to the shelters?
Well, I can speak a little to that. I know our shelter, Maple Street, is a dry shelter. So there is what they call wet shelter, which would be the mission where people can be drunk and so on. But Maple Street doesn't allow that. So it just depends on the shelter that they go to. But we try to make sure they're going to an appropriate shelter. And Peter, I'm sure, can speak to it better than I can.
That was a question queued up for me perfectly. So we consider homelessness and being in a shelter a crisis, and that you want to prevent people from ever having to go into a shelter in the first place. And if they do have to go in, their stays are brief, non-recurring, and that they're rapidly housed in permanent housing. That's what the housing first approach is all about. So to avoid the whole crisis and many other challenges and issues that you'll face in being in an emergency shelter. So what do we have available? Harbor Homes has more than 900 people in housing across the state of New Hampshire. We have about 34 properties that we own, and we have many other hundreds of housing units that we provide rent subsidies for, so people will have an affordable place to live. We offer around 80 different programs, and it's very complicated to try to explain the details. Sorry about the red tape part. But we do have a great deal of resources, and everyone that comes in that door, we try to treat them as an individual, special human being, getting every respect that we can possibly show to them. When you walk into our clinic, you are brought right up, and the first thing we do is we offer you healthy foods. We have a licensed kitchen back there where we provide a whole array of healthy things, and there's no charge. So we really try to focus on getting someone so that their very basic needs are addressed first, and then we really figure out things after that. So there's many more answers to that question, but that's kind of the summary answer. Thank you.
Any more questions before we move on? Our next counselor is Tara Richard, and I'm going to have to read this so I get it right. She is a mental health counselor, but in addition, she is here we go, Integration Coordinator for the Harbor Health Care and Wellness Center. And that wellness center is what you can take a tour of with Tara after this is over, if you choose. Tara.
Hello. Can you guys hear me okay? A little voice. David, thanks for sharing your story. That's wonderful, really empowering. Something I think that you guys can notice while you're hearing each of us speak and each of us talk about client stories is that mental illness is different for everyone, and so is homelessness. So Harbor Homes has to be
able to work with people who have all different kinds of mental illness and all different levels of homelessness. So we're called the Harbor Care Health and Wellness Center, and that's what I like to think of Harbor Homes as. It's a full wellness center. So I'm an integration coordinator. So you guys may have heard this word integration. It's a new thing. It's not really that new. But for us, we feel like we are pretty close to being fully integrated, which means that someone comes in here with one issue and we treat not only the one issue, we treat their whole person. So we have, as Susan mentioned, we have primary care, behavioral health, and dental, along with other partnership services that we're able to offer. So you come in, you fill out an application. Speaking to your question, we can get a walk-in, we can get a phone call, we can get a referral from the hospital, we can get a referral from another agency. All we need is you to fill out an application and we can get you started right away. We have a patient educator who can sit down and help you fill out the application. It can be long and overwhelming for some people, so we offer that service. That same day you could get your appointment schedules made. So you may come in thinking that you have a behavioral health issue. And this is a story that's actually happened. Someone came in for severe depression and they were seen by a therapist. The person had a really bad toothache that they had been dealing with for months on end. So we then referred them to our dentist. Depression gone. No more pain. You know, so someone who may not understand that they're depressed related to another issue, and that's where the wellness piece comes in, the integration. So in every medical appointment, people are screened for depression and they're screened for substance abuse. So if there are any elevated levels, we immediately refer within our own clinic. We work as a team. We have team meetings, so we're always talking about what's going on with people's care, anyone that works on their treatment team. As far as housing, we obviously work with housing as well, and housing can definitely impact mental health. So the clinic is a really great community. We use all our resources. We roll out the red carpet, as Peter says, almost every day. If you come in here and you are part of our agency, we'll roll out the red carpet to offer as many services. It's one-stop shopping, trying to make it as easy as possible for people to get help. Oh, yeah, I'm sorry. Yep.
You invited me. Sorry.
So we just did the UDS report, which I have not memorized. A rough range, Peter, do you know?
The agency as a whole serves over 10,000 people. The clinic has last year served 2,200 people, 2,200 patients. We serve children, adolescents, so the full range. We serve about 60% women versus men. We are proud about the fact that we just invested very heavily in a new software called Client Track, so that we're really going to be able to tell you with great precision about how people came to us, what happened when they get our care, and what happened in the year or two after they got our care. We have a hypothesis that we try to test here, that when people receive services through the partnership agencies, that the impact on their lives is more profound very often than, say, what somebody might get if they just get services through kind of a single-purpose nonprofit organization. And that's one of the things that we're endeavoring to prove.
I don't want to re-ask the same question, but age groups, I mean, is it like 15 to 35, or is it over?
What's the youngest?
Do you have the answer, Carol?
We see a lot of elderly.
We have a fully. Go ahead, Carol Furlong, our Vice President of Operations.
Are males after the age of 55. Most of them have either no children or grown children. But we're increasing unfortunately, we're increasing the number of young women with kids. So we're beginning to treat more and more children now.
Yes. I have a question. We have legislation on health care in the legislature at the moment, and I was wondering how much passing that type of health care affects your clients.
I think you're referring to the New Hampshire Health Protection Program that just recently got voted by the House to continue for another 2 years. That program is vital. It saves people's lives and has been indispensable in the work that we do. I can't tell you the number of times that we see our patients walk up to the window and so very proudly display that health insurance card compared to the days before when they had no insurance and really were just ashamed. Now they feel, I've got insurance. And I will say to you too that as somebody that has been doing this work for a very long time, I've spent a lot of my life at funerals where I've seen people pass away far too early in their life. The lifespan for somebody with serious mental illness is at least 15 to 20 years less than the average population. And by having this health care in place, I'm very certain that we're extending people's lives to the way they should be. So I think it's just been a godsend, and I cannot thank the legislature and all of those people that have been powerful leaders in making that continue. So thank you.
Any more questions? Tara, we'll turn it back to you.
Okay, so when I thought of a client that I would want to speak to tonight, I thought of Deena immediately. Deena and I worked together about a year and a half ago doing something called illness management recovery. It's part of, it's a therapeutic tool to use. And Tina's used a lot of the programs in Harbor Homes, and I think she would be a perfect person to talk about how it's affected her from homelessness to where she's at today.
Hi, I'm Deena. When I first learned about Harbor Homes, I was homeless, and I learned about Harbor Homes from word of mouth on the street. I was living at the women's shelter on Kinsley Street through Soup Kitchen, actually, that got me in there. So they're a big part of my life, too. Through the beginning of I had no insurance, I had nothing. I was depressed. I was so lost. I was lonely. I didn't know what to do. I was confused. I was ready to just give up. And Harbor Homes managed to help me get my Medicaid at the start. Started seeing that I also have a mental illness of bipolar depression. So I was able to start seeing different people to help me in different areas. I'm also have a drug and alcohol addiction. So I was seeing a lot of different people. Today, and not only that, my primary care doctor, she's a big part of my life as well, Joanne. She has done tremendous for me, especially with my addiction. She has tried so hard to get me to stop. Tara has also worked with me with my addiction back in the day and tried to wean me down, which we did very well with that. And then they have a program that is the dentist, he's fairly new here, that also help people that are involved in Harbor Homes for your income, because a lot of us might have SSI. So I'm involved with the dentist, and I'm now going to be getting my jaw and my teeth, whatever, fixed, and it's affordable for me because I am on SSI. I also see Susan as my therapist psychiatrist, and I'm on medication, and she got me stable at a better pace with my bipolar. I'm not so manic anymore, and I'm able to take my time and think before just lashing out or whatnot. Harbor Homes saved my life, especially from the depression and the addiction and the homelessness. I am no longer homeless today. I have a great life today. I am sober today. I have 15 months clean and sober as of today.
clean and sober, it has taken a big change in my life, a tremendous big step that I'm also in college trying to be a veterinarian tech assistant. That's also another an accomplishment. And the biggest accomplishment that I have just received was because of my addiction and everything in the past, I was carrying Hep C in my body for over 15 years. I no longer have that in my system because of Joanne gave me the medicine, and that's also been cured. And that's because I'm clean and sober. I'm just really grateful to be here to help. Harbor Home saved my life. It really has in so many different areas. I don't know what I would do without them. I don't know where I would be. I don't know if I'd even still be here. I know that I lost my brother from the addiction of heroin, and he died. He was homeless as well, and people tried to help him, but it was too late. So with that too, it's made me stronger to not want to go out like that myself, because I could have. And I have relationships with my children today, being clean. I've also gotten my son. One of my sons involved. He's involved with Harbor Homes because he had no insurance. He had nothing. So he now also comes to Harbor Homes. And he's doing wonderful today. He's got a good job. I'm very close with my oldest son, which I never had relationship with him ever, because of my past and because of my homelessness, because of everything. I was a mess. And me and him have such a bond today that he actually calls me Ma. He never called me Ma before, and he tells me he loves me, and that's a gift. It's an actual gift that I can be grateful for. But I'm just really glad to be here to help, and I will do. And it's also, for me, a way of giving back. Because of my addiction and everything, I do help the homeless. I know what it's like to be out there, to suffer, and it hurts. It's sad. So I know how to help and how to give. I know how to give advice. I do a lot of research myself. I also used to be involved with a homeless outreach program in Massachusetts back in my past. So I have a lot of knowledge when it comes to stuff like that, and I want to keep going forward into helping and just get myself involved in things to help others, because it's a need. And I'm grateful to be here. Thank you. That was another thing. Through Harbor Homes, they have a program to get you started on your feet. Because I was homeless, working my way up. They have a program. It's for housing, and it was for 6 months only. They would pay 80% of your rent. You paid 20%. So through that program, I was able to get on my feet. They helped me through the 6 months. After 6 months, you're on your own. But within that 6 months, I was able to get ahead, and I was able to move from that place, because it was a studio, but it was a start. And then I was able to work my way up, and I'm in a one-bedroom. I've been there for over 2 years. I have a great man in my life today, and I have an emotionally support service dog. And he also saved my life 3 years ago. So, and I also have the responsibility of learning how to take care of pets, because of my own experience. This is what I want to do for work. I want to go back to work. I don't want to be on that society no more. I'm capable and I'm able to also help animals. As a way of helping people, because I'm also a certified nurse assistant in my past. So yeah, it was a lot. Harbor Homes is the best. You're welcome.
Thank you, Tina.
You're welcome.
Any more questions? Yes.
Another question.
For individuals who may be suffering addiction problems with opiates, what programs might Harbor Homes offer regarding medication outpatient recovery programs? I think I read something about that recently. I was wondering how that relates to what you're talking about here and how that fits in the overall picture.
Well, I can speak to that a little bit. So we have a Suboxone program, and that requires MDs. So far, the federal government doesn't allow APRNs to administer Suboxone, but we have an MD who's our psychiatrist and another MD who's the medical director. So Dr. Misra and Dr. Graciela, and they both administer Suboxone. We're also starting very shortly, and I think the goal date was April 1st. I'm not sure if it's going to be quite that soon, but a medication-assisted inpatient detox program, and that will be over at the Keystone location, which is over on Amherst Street. And then some of from what I understand, some of the patients may end up in this building as well that are medication-assisted patients.
If I can just kind of add on to that, so one of our 6 agencies is Keystone Hall, and they exclusively provide substance use disorder treatment services. Their outpatient department is located here in this building upstairs, and they have 8 licensed alcohol and drug counselors here. They have walk-in services most mornings during the week. You can call in, and you'll be able to walk in and meet with a licensed alcohol and drug counselor, and they will make an assessment and try to figure out what it is that you might need. We have so someone that might assess you might decide that you need an outpatient program, you might need an intensive outpatient program, you might need medication-assisted treatment, you might need outpatient medical detox, or you might need a residential medical detox, or you might need what we call a long-term residential program. And Keystone offers at 615 Amherst Street here in Nashua a 54-bed licensed treatment facility. It's one of the oldest organizations in the area that has been working with substance abuse, and they are a key part of our integrated team. As Susan talked about integrated care in the clinic, it's probably not obvious to people that, we all go to our primary care doctors and we go into the exam room. What's different here is that when you go and see your primary care doctor and they screen you and you have other issues, the medical provider will offer you the opportunity to right away come right into the exam room a licensed alcohol and drug counselor or a mental health specialist, depending on what it is that your needs are. So that's that's how integrated care is delivered. So I hope I answered you, but there's more pieces to that as well. But so it's a pretty extensive program.
More questions? Carol.
So, for those of you who know me, and a lot of you do, you know that I'm so proud of working here that it's hard for me to keep quiet. So I'll apologize up front. I'm sitting here and listening to all of this, and I'm remembering my first experience with a homeless person was when I was 6 years old. Back then, in the dark ages, for those of you my age, we called them hobos. And they walked from house to house looking for some way to earn money. And at 6 years old, I remember my grandparents letting them do odd jobs around the house and asking my grandparents, why? Why do they have to do this? How come they don't have a real job? And I remember my grandparents saying, everybody's entitled to take pride in what they do. So here I am, almost 60 years later, and I'd love to be able to tell you that that was the beginning of my desire to work with the homeless population, but I'd be lying. I stumbled into this. What I know now is that nobody wants to be homeless. We have this stereotype of the homeless population, don't we? When you ask the general public about homeless people, they describe the stereotype. Back then, most of them were veterans who, because of difficulties after the war, mental illness or addictions, couldn't find work. The picture of homelessness now is much different. We're seeing younger people. We're seeing females. We're seeing young mothers with babies. And so how do you address those issues? Many of you here, I know your faces. You deal with them every day. And the way we choose to deal with them here at the partnership is not only to integrate between our medical care and our behavioral health care and our dental care, but also to work with all of those partnership agencies. So here we have Wendy, who works at the HIV Task Force, and Darcy, who works at Milford Regional. And if I have a patient here who needs any of those agencies or any of the other agencies of our partnership, we're really fortunate in that I can call them and we get services for them right away. That's kind of the purpose of this meeting, is to stress that it takes a community, doesn't it, to make changes. And this is the best one we could have.
Thank you, Carol. Any other questions or comments? Yes.
Thank you, because hearing from you, I am emboldened to get up. I thought we were only to ask questions, but now that I've heard from her, I can release my comment because it's been boiling inside me. I am so glad. Thank you, Mary, for letting me know about this. Yes, because homelessness has been something that has been causing me sleepless nights. And way back in Nigeria, where I come from, many of us have this huge admiration for the United States of America. Huge respect. If you know where we place United States of America, only for me to step my feet on the soil of the United States of America for the first time in 2004, because my baby came over here to study through the SAT exams. I'm sure many people know about SAT. So, as a very busy working mother, I had to come with my husband, who had been used to coming for a number of professional things here. I had to come because I needed to follow up on my baby. And that was the first time that our host in California took us to downtown LA to see the number of homeless people, because I couldn't believe that such a thing is happening here. But I saw it live, and that pain just got embedded in me that, no, it cannot be happening here in the United States of America. My background is not something I will start discussing here, but I fell in love with the United States of America through my professional exposure, starting with the United States Information Service in one of our cities in Nigeria, Kaduna, and the United States Information Service officer also fell in love with me because I was the chairperson of the Media Women, Association of Media Women, Nigeria. So that sort of catapulted me into, even though I was living in Nigeria, I was sleeping in the United States of America. So having come here with the kind of respect, the kind of ideas I had in my head about, and let me tell you, America is great. Very magnanimous people. You've achieved so much, and anyway, I thank God I'm now one of you because I'm a citizen now. But this thing that started bothering me is something I have been presenting to God in prayers. And I'm so glad to hear this because it shows that God is answering prayers. Some people are busy doing something about homelessness. And like you said, yes, most problems start with homelessness. Most of the problems we see, most of what we are being shown on television, homelessness starts. So I am so glad to be here, and I tell you, please, thank you. Let others know that there are many people there thinking about them, thinking of what to do to make sure that they will not go through what you have described or what you have described. I believe that homelessness will be addressed because many people are concerned. It's not a question of they and us. It's a question of us. I thank God for my GSOP friends. I walked into that door. I met a number of you. I'm glad that I am in the midst of people who share similar values. We shall make it together. These problems will be finally dealt with. Thank you for your great jobs.
Name.
I am Noni Ebuono of the Main Street United Methodist Church. We are your neighbors here.
Thank you very much. Someone else had their hand up, and I don't remember who it was. Bob? Bob Keating and Hillary founded the Ending Homelessness Fund. They have worked at this for decades, and their efforts have been responsible for housing many of our chronically homeless, the most vulnerable of all in the homeless people. And he wants to say something.
Well, I think you're given a lot more credit. This is the place that Harbor Homes and many other people who are not here who have given enormously. And I want to thank David and where Elaine Thomas is over there, and Julie Haas for their efforts in putting this on. It's much appreciated. Word. And I want to say to the panelists that I was touched by the stories so much. All of you, David and Tina, to sharing the way you shared. I think helps us all. At my father's funeral, I read a reading, and just vivid. It comes back to me all the time. And it ends with, all our lives we are in need, and others are in need of us. And I think that Peter's, the work just has been enormously successful. But the word about integration, I think has, for me, multiple meanings. There's no distinction in my mind about what role any one of you, of the panelists, have been up there. You are all helpers, all givers, and all of us need to receive too. And Ronnie, who I happened to get to be part of her 70th birthday celebration, which I said to somebody coming in, that I've never been to a birthday party where people were from the widest spectrum of our birth. And that was their party. And she also said something that I've said to Peter repeatedly. I've known Peter almost the whole time that he's been in Nashua, which is, I sleep better because of Harbor Homes and the work here. And I think that's really true for everyone, that when each one of us is better, we're all better. And in the same way, the pain of each and every one of us ricochets right through. And like Hannah says, who comes to America and sees it, it shouldn't be, it never should have been. We have too much wealth in our country to explain why we're in the position we are. So thank you all for your work, and collectively for the partnership for successful living, and all of those who are outside of our doors who give. And one of the guys is Bob Mack over there, is our welfare director. If you don't know him, he's been instrumental in keeping the focus on through all kinds of times.
He's a saint.
Thank you, Bob Mack, and thank you, Bob Keating. Any more comments or questions? Yes. Wear down this rug.
I have one more question specific to the homelessness piece. What is the waiting list or the queue or the people who are currently, or how many people are waiting housing today? How many housing units are available, and what resources are needed to help improve the situation for people who may be waiting?
That is a question that is a bit complicated, and the biggest demand that we have are for people who are in apartments that they can barely afford, and they are struggling to figure out, how am I going to pay the rent, the utilities, or perhaps it's a family jammed into a very small place, and they're really just looking to get into a more livable situation. For that type of a list, and we call that affordable housing, the list is in the hundreds. I think the last time I heard the number was around 800 people. Right. That's just for here. And at the State Housing Finance Authority, the number I think I heard recently is 11,000. And then at the local Nashua Housing Authority, you may know a more recent number than I know, but I think it was around 5,000 or so. 10-year wait, yeah. So for those kinds of housing situations, the list is very long and highly competitive. Where are the units? Where
are the people?
Well, those people are in and out of homelessness, substandard living situations, overcrowded, couch surfing, yes. And then we have others, say, that are literally homeless. We have an emergency shelter. In this city of Nashua, we have 3 emergency shelters with a cumulative bed capacity, I think it's around 70 altogether. And there's a lot of times when they're completely full. There's maybe it's 50-50 where there's a bed here and there across the different shelters. So if you're literally homeless, there's a 50-50 kind of a chance, and there's not really a long waiting list for a bed available immediately. And then there's other kinds of housing that we do. If you're a homeless veteran, for instance, we have a pretty significant amount of resources to assist you. I've spent an enormous amount of my time lately trying to figure out how to reduce the number of homeless veterans in emergency shelters across New Hampshire. And for years we've had 50 to 100 veterans in all of the shelters. And actually today, for the first time, we now have that number across the entire state to single digits. So that's taken about 6 months. Thank you. But depending on the population and the need, there are faster waiting lists is kind of the answer. So we get funding, and the funding comes with restrictions, and we have to figure out how to be as responsive to the people that are desperately in need of the services, and at the same time honor all the regulations and so forth that we're bound by. But it's I say don't ever be discouraged. Just try, and you might be surprised if you had, say, I'll tell you another program. If you had a serious mental illness and you were looking for housing, we operate a program called the Housing Bridge Program statewide, where we have 400 units of housing. So there's different categories, and that's one of the biggest ones. You had another question?
Yeah. Are certain folks prioritized, like they were talking about the moms with children? Are they prioritized over somebody else, that type of thing?
Yes. it totally depends on the program. So about a month ago, we just opened up a waiting list here, and we prioritized homeless veterans, and we prioritized single parents with children. And we, within a 2-day period, had over 200 people that came here and applied for that. And the last time we opened up that list was 2008. Mm-hmm. More federal than state, but we're subject to all kinds of regulations. Okay? Thank you. Oop.
I have a little story about prioritization. I took a tour of Keystone Hall, the largest center in the state for addiction. And so you go around, and here's a cafeteria, and against the wall of the cafeteria is a row of high chairs. Why high chairs? Prioritization. Can't say the word. If a woman comes in and is in need of withdrawal and care and pregnant, she goes to the top of the list. And many of those women have little children. They go in with her, and they get the high chairs. Any more comments or questions? Eddie.
A few years ago, you had tours where people could go around and see some of the housing units. You had 34 houses at that time in which people were being housed. And I've heard some friends who might like a tour like that again. Are you going to do that again?
Tour master extraordinaire. I think I've given, I don't know, probably 250 tours in the last year. But, you know, we're always willing to give tours, and we want people in our community to know about all the things we do. So, yeah, please. We have several types of tours. You know, we do tours in this building of all of the activities here, and then we have done tours where we take 20, 25 people at a time with several vehicles, and that's a 3-hour tour. So depends on your time.
Any more? Yes.
Is there any outreach to schools or integration with schools, be it for homelessness?
Cue Dave Howard. Doug Howard, yes.
So my position with Harbor Homes is I am the local liaison for the Nashua School District, and I work within all 17 schools in Nashua, and I coordinate services for students who meet the McKinney-Vento law standard. So McKinney-Vento is the definition for McKinney-Vento homelessness is different than HUD's, and it's intentionally more broad to cover a wider range of students and to make sure that they have the same equal opportunity to a free public education. Cool.
Why don't you tell them the numbers you told me about people in the broad?
So right now, actually, I just right before I came over here, I was over at Maple Street, and I was looking over it on our online portal for the school district. We have 262 identified young people that would be considered homeless under the McKinney-Vento Act. For those who aren't aware of the McKinney-Vento Act, that means the standard is these young people don't have one of these three things or a combination of these three things: a fixed, regular, or adequate housing situation. So, for instance, we could have a young person sleeping out in a car. That's clearly not adequate, nor is it fixed, or nor is it a regular thing. We can also have a family. So, for instance, if me and my wife and my 3 kids, we get evicted, now we have to go live with my friend Bob. Bob lives on the other side of town. My family and my kids are still protected under the McKinney-Vento Act, my children are still allowed to attend their same school that they originated in, and they do not have to move in order because of our homeless situation. It's the school district's responsibility to keep my kids where they are.
My name is Jack Flanagan, and I'm a legislator, one of many here. And of course, Peggy's going to come back, I'm sure, or try to come back in the Senate. I introduced a piece of legislation sort of on the same note with the students, that Health and Human Services can't remove the child from the school until they work out a plan with the school. So it actually will stop, in case of a homeless person, the ability for HHS to step in and say they're moving. So you might want to keep that in the back of your head, because that law will probably pass.
Thank you, Jack. Yes.
Hi, my name is Laurie Goodman, and I work here helping people to get insurance through the Affordable Care Act. When you hear everything that's been said today, and you see all the people here who really care about what they've heard, and you hear that we're meeting again on September 21st, was that the date? I would really like to encourage everybody who is here and has been moved by what they've heard to plan to return on September 21st with as many friends and family as you can bring with you, because it is resources and it is people that are going to make the difference. So I'm going to give you that charge today, if you don't mind.
Thank you. Thank you. I've got too many mics. Any more? We're about at our stopping time, so let me first introduce again the two people on the educational forum who are here, Elaine Thomas and Julie Beck Goss, and we have a big vision. The staff of Harbor Homes. Well, I would suggest that you realize we have heard from 3 staff members, and I guess, Peter, you're a staff member, and several in the audience, but there are so many people. I think that's mine. Can you shut it up? That'll show them. There are so many people behind these walls and in other buildings that are doing this day in and day out that we never hear about. And I'm so pleased that we got to showcase 3. And we got to showcase, of the 900 people that Peter says he's taking care of now, I think that's the right number, we got to see and meet 2 of them. And let's give them a hand. Tina, Tara, David, Susan.